Good evening to all of our listeners, and a big hello from me. I'm Dr. Sonia Davison, the President of the Australasian Menopause Society. I'm really thrilled because there's heaps of you who have registered, and it's going to be a really great webinar. Firstly, I'd like to acknowledge the traditional owners of the different lands that we meet on this evening, and I'd like to pay my respects to their elders, past, present, and emerging. And I would like to therefore introduce to you Professor Susan Davis. Many of you will not need to be introduced to Professor Davis. I've known Sue for a long time. When I first saw her talk at the International Congress of Endocrinology in 2000, and I thought, ooh, who's that? Little did I know I'd be working with her a year later, and that's been an absolute pleasure for me and a thrill, and she's introduced me to this amazing world of women's health. Sue is an NHMRC Senior Principal Research Fellow and the Director of the Monash University Women's Health Research Program. She's a consultant endocrinologist and health specialist at the Women's Health Clinic for Women at the Alfred Hospital in Melbourne and a consultant at Cabrini Medical Centre. Sue has done extensive research in women on sex steroid physiology. She knows a bunch of stuff about estrogen and about testosterone. Sue is really highly regarded, not just in Australia, but wherever you go. People say, oh, Professor Davis, of course, and she's really highly regarded. She's done some really amazing research, and she's been very kind and supportive of younger researchers, and I was very fortunate to do a PhD with Sue, and that was a real pleasure as well. I would like to introduce you all to Professor Susan Davis, and I hope you really enjoy the webinar. Thanks so much for attending.
So it's very difficult to cover this topic and do justice to it in such a short time. So I hope that what I do cover gives you certainly enough information to enhance your practice and maybe pique your interest in this area. I'd like to say that the views I will express are my views and not necessarily the views of the Australasian Menopause Society. And also I have produced this presentation completely independent of any funding. I'm not being paid for this presentation, and the slides are all of my own. So with that, I do need to declare to you my potential conflicts of interest. Any research data I'm presenting to you this evening or this morning in some parts of the world is work that's been funded either by the National Health and Medical Research Council of Australia or a philanthropic grant from the Grollo-Rosine Foundation. So these are the areas which I wish to cover, and as I said, somewhat briefly, but certainly across from physiology through to prescribing. So you will all be aware that androgens are produced from both the ovaries and the adrenals. And the ovary secretes testosterone directly into the circulation, whereas the adrenals predominantly secrete the precursors, androstenedione and DHEA sulfate, which are converted to testosterone peripherally. Testosterone can then act, I'll go backwards here. Testosterone can then act either directly or through conversion to dihydrotestosterone, or be aromatase to estradiol and act directly on estrogen receptors or act non-genomically. So it has sort of pleiotropic effects because of this whole range of activities. Now, we previously have reported that testosterone falls by about 50% between the age of 20 and 40, but our more recent study looked at premenopausal women aged 80 to 39 years of age, and we measured androgens by liquid chromatography and mass spectrometry. And here you can see the change in testosterone with age, androstenedione and DHEA, and these values are adjusted for cycle phase and also for body mass index. When adjusting for these things, you can see testosterone falls spontaneously across the reproductive years by about 25% through to DHEA falling by 36%. So by the time women get to their late 30s, they have substantially less androgen production. Now, this is actually work from Sonia's PhD, and my little red diamonds moved across. Don't you just love technology? So this is work from Sonia's PhD where we measured testosterone by radioimmunoassay. This little red circle belongs over here, where it demonstrates that there's actually a decline with age, like I've spoken about in the premenopausal years, and there is this nadir in testosterone in women around the age of 62. And so you can see here there was this suggestion that beyond the age of 62, there was possibly an increase in testosterone. But we were very limited to what we could say about this because there weren't a large number of women in this age group in the study. What's really interesting is that we've been able to measure testosterone in nearly 7,000 women aged 70 to 94 years. And these are relatively healthy older women. They're all living independently in the community. And they are women who are free of major cardiovascular events. So they've not had a heart attack or a major cardiovascular admission to hospital for any reasons. And they're cognitively intact. They don't have cognitive impairment. And what we found using mass spectrometry is that estrone increased slightly with age from 70 to 94, but testosterone surprisingly increased by about 11% in these older women. This is despite the precursor for testosterone falling with age. And what's really fascinating is that the median levels of testosterone in these older women was identical to the median for premenopausal women using the same assay. So this suggests to us that there is possibly some survival advantage for older women having testosterone higher levels. I said we measured testosterone around 7,000 women. We excluded the women from this analysis who were taking any medication that by any way could interfere with their testosterone levels. So these are relatively healthy women on no exogenous steroids or glucocorticosteroids, etc. For very provocative data. What else so causes low testosterone in women apart from aging during the reproductive years? Well, ovarian insufficiency will cause a reduction in testosterone. And here you can see an example of why, because you lose the production from the ovaries. Now, this can be by surgical menopause, it can be by premature ovarian insufficiency, or you can cause ovarian insufficiency by switching the ovaries off with something like Depo-Provera, or most commonly the oral contraceptive pill. So everyone thinks that the oral contraceptive pill creates a problem by increasing SHBG. In fact, the main problem the oral contraceptive pill creates is switching off the ovarian function and ovarian testosterone production. If a woman has adrenal insufficiency, she will lose 50% of her testosterone production. And we as clinicians create this by treating women with prednisolone and other glucocorticosteroids. So that would be the most common cause of the adrenal loss of testosterone production. If a woman has panhypopituitism, she will have loss of adrenal ovarian function and therefore be profoundly testosterone deficient. Now, we induce this commonly in our patients by putting them on the pill and then treating them with glucocorticosteroids. So the iatrogenic cause would be the most common cause of creating a pseudo panhypo effect in terms of testosterone production. And we tend to replace these women with estrogen, but we don't remember to give them testosterone. So testosterone has been a very, very provocative area in terms of treatment of women. And the use of testosterone in women is somewhat widespread, under the radar, often inappropriate use of male formulations and compounded therapies. So one of my outcomes as president of the International Menopause Society during my presidency up until last year was to assemble the Global Consensus Position Statement. Now, this was an important statement, firstly because it's the first global statement guiding the use of testosterone in women, but secondly, it showed that societies which usually produce their own individual statements on, say, HRT or early menopause could actually work together and produce a harmonized statement so that the guidance for doctors all over the world is the same. And here is a photo of the majority of the position statement members that were nominated by their society and met in Berlin. There was no pharmaceutical funding for this. And we produced the statement, which I'm going to go through with you in brief, that was published in 4 international journals. So what were some of the outcomes? And this really is the nuts and bolts of using testosterone in women today. Well, we talked a lot about the physiology of testosterone, its complexity. And this is because it binds variably not only to SHBG and albumin, but also to cortisol binding globulin and a protein in the blood, circulating the blood called orosomucoid. Its biosynthesis is not just simply from the ovaries and adrenals, but a lot of the biosynthesis happens in target tissues. And it's also metabolized in target tissues. So what you measure in the bloodstream might tell you nothing about what's actually going on in the cells. So that's why blood hormone levels are very poor guides to tissue levels and tissue action. So this applies to most sex steroids, but very importantly to testosterone. So testosterone comes along as a sex steroid. It can bind to a cytoplasmic receptor and then be transported into the nucleus and trigger DNA. It can act through a membrane-bound steroid receptor, or it can also independently trigger G protein coupled receptors. And then we know that in addition to this, testosterone may appear in the cell after entering the cell as DHEA, as DHEA or androstenedione being converted into testosterone within the cell and then acting through one of these intracellular mechanisms. Then it gets really nasty because how a sex steroid acts on its receptor is modified by tissue-specific coactivators and receptors, transcription factors, and the action's modified by other intracellular steroid concentrations. So it's all rather overwhelming, but the bottom line is simply measuring testosterone or estradiol or progesterone in the serum will tell you nothing about what's actually happening in the cell. It's a very blunt measure. And then we used to get very focused on free testosterone, everyone, including me. But we now know that how testosterone binds to proteins is very poorly understood. And this shows you the various ways testosterone can bind. We know that testosterone or SHBG has 2 binding slots for testosterone. And we assume that binding is linear. But in fact, it probably isn't linear. So the rate at which testosterone binds SHBG may vary according to how much testosterone is in the serum, low versus high concentrations, and the concentrations of other sex steroids in the serum that bind SHBG. Furthermore, there's no evidence that free testosterone is biologically active. In fact, it may be the portion of testosterone that's most readily broken down in the serum. And as well stated in an endocrine review in 2017, measurement of free testosterone levels is fraught with potential problems because of the reasons listed there. When you use the different methods or formulas to estimate free testosterone, you'll get a different answer for every SHBG value and total testosterone value that you plug in to each of these 3 equations. So the bottom line is total testosterone is what should be measured, not free testosterone. And testosterone should not be used to make a diagnosis of sexual dysfunction in women. It should be measured to avoid treating women with an unexpectedly high level and should be used to monitor against overuse of testosterone therapy if a patient's prescribed testosterone. And this is also to highlight that the measurement of even total testosterone is challenging. This is because the concentrations in women are low, and for most assays, there is great imprecision at low levels. Radioimmunoassays suffer from cross-reactivity with other steroids, such as if a woman's on norethistran, the cross-reactivity is quite substantial. And for most assays that are available in the general community, the normal ranges are based on very small numbers of women. If you're looking at something like PCOS and you're looking for a high testosterone, the immunoassays correlate well with mass spectrometry. But at low levels of testosterone, all immunoassays correlate poorly with mass spec. So these need to be seen as an estimate of testosterone, not as a true value. Talk to your laboratory, ask them about what lab measures they're using to measure testosterone. This is a radioimmunoassay, and even ask them what their reference ranges are and how they were developed. So that's the physiology and the biochemistry. So what about treating women? Well, the conclusion was by this expert group, based on the available data, there is only one evidence-based indication for testosterone therapy for women, and that is for the treatment of postmenopausal women who have low sexual desire with associated distress, or what we call HSDD, with available data supporting a moderate therapeutic effect. There are insufficient data to support the use of testosterone for any other symptom or clinical condition or for disease prevention. So you shouldn't use it to treat depression, you shouldn't use it to treat bone loss, and you do not use it to prevent diseases like breast cancer, despite what some people are suggesting. So I'm not going to go into the classification of female sexual dysfunction in detail, but the recommended classification is the ICD-11. If you want to look into this further, there is a white paper from the International Menopause Society from 2018 that I think it's 2018 or 2020 now, I'm not sure myself, 2020, that you can get by going onto the International Menopause Society website, and it's freely available there. Hyperactive sexual desire dysfunction is reduced or absent loss of desire and or loss of desire to erotic or responsiveness to sexual cues and or inability to sustain desire. It's not all three of those, it's one of those or many of those. Now I'm going to show you a whole lot of slides that look like this. And this is from the meta-analysis that we did and published in the Lancet in 2019. And it is data from the all published and unpublished randomized trials of testosterone in women. There were at least 12 weeks in duration, and that included a comparator and in which the participants were blinded. And what you will see is you'll see the, it's called a forest plot, where on one side of the zero it favors comparator and the other side it favors testosterone. The big diamonds are the summary statistic for all of these, for all these different studies. And if the big diamond and the confidence intervals are on the testosterone side, that means the outcome favors testosterone. We went a step further than is usually done. This first subtotal result is the summary of all published studies. Then there's a thing called the prediction interval, and that says if we were to be overcautious and we notice that the studies have heterogeneity, that means this I-squared statistic. If the studies have heterogeneity, is there a possibility that if we repeat these studies that we may not find what we found before? And if this prediction interval, confidence interval, crosses the 0, it means future studies may not always get the same outcome. So here for satisfying sexual events, the available data shows a benefit of testosterone over placebo, but there's a slight cross of the prediction interval over 0, so there is the possibility that a future study may not get the same outcome. What about sexual desire? Well, for surgically menopausal women, both the prediction in subtotal and the prediction interval shows you that there's a benefit. For women with natural menopause, current studies show a benefit. The prediction interval says you may not always see it. And when you put it together, there's a significant benefit from what we know, but you may not always see it in the future. Now we go to arousal. No heterogeneity between studies. The studies were very consistent, and there is no prediction interval because basically the data is just so conclusive. There is a benefit of testosterone on arousal in postmenopausal women with HSDD. The same is seen for orgasm, improved with testosterone therapy in women with HSDD. Sexual distress is significantly reduced, a marked reduction across all studies. But I do want to say that these studies were women assessed as having HSDG or generalized sexual dysfunction. Recommendations cannot be generalized to other types of sexual dysfunction. So, for example, if a woman comes to you with anorgasmia but is interested in sex, there's no evidence testosterone is going to help her. There was no benefit in premenopausal women. And in fact, when we extended our study in premenopausal women and looked at associations between androgens and sexual dysfunction, there is a weak signal that androgens influence sexual function in premenopausal women, but it is a weak signal. And so there's no diagnostic use for testosterone diagnostically in premenopausal women, and also consistent with the evidence that it may not benefit premenopausal women with low sexual function. And therefore, consistently, presently, there is insufficient data to use testosterone as a treatment for premenopausal women with HSDD. What about other outcomes? Well, the systematic review and meta-analysis did not support an effect of testosterone on any of the outcomes I've listed here. So walking you through this, there's no evidence that testosterone had any effect on lean mass or total fat versus comparator. There was no benefit for depressed mood or low well-being. And the subsequent RCT looked at testosterone for women with major depression and found absolutely no benefit in women with major depression, consistent with what the previous studies had shown. Importantly, all the studies I have shown you are data for testosterone replacement that results in approximately physiological testosterone concentrations that one would see in premenopausal women. So none of these were studies that produced very high testosterone levels. So with the caveat, what we concluded in the global position statement was that the treatment has to be physiological. What about safety? Well, we considered all these safety outcomes, both in the meta-analysis and in the global position statement. So looking at androgenic effects, there was no evidence that testosterone across studies resulted in alopecia, clitoromegaly, or voice change. There was clear evidence that there was a tendency for treated women with physiological levels may report some acne or increased hair growth. Now, I will highlight the fact here that we did not control for the blood levels that resulted in these studies, and that the hair growth is not hirsutism. Many of the women reported that they were now shaving under their arms or shaving their legs where they hadn't for months to years. So there was no increase in women dropping out of the study for androgenic effects. In fact, interestingly, across these studies, women were more likely to withdraw from the study if they were in the placebo group than if they were in the testosterone-treated groups, which actually made the analysis for many of the studies difficult. What about weight gain and BMI? Well, of the studies that looked at weight gain, and there were, BMI, there were very few women in the studies. This shows you the number of women in the studies. More of the studies look specifically at weight gain. And when you look at weight gain, there's a small trend for a small increase in weight with testosterone in women treated with testosterone. Oral testosterone is associated with adverse lipid profiles with a reduction in HDL cholesterol and an increase in LDL cholesterol, and it's strongly recommended that oral testosterone is not prescribed to women and indeed not prescribed to men as well. Transdermal and injectable testosterone was not associated with significant adverse effects on lipids over short term, that's up to 2 years, in doses that approximate physiological levels. It was also not associated with any other metabolic effect, change in CRP, change in insulin resistance, and so forth. Testosterone does not increase mammographic density, and this is results from placebo-controlled studies. The data is insufficient from randomized controlled studies to assess long-term breast cancer risk. The data from observational studies indicate no increased risk of breast cancer, but that's from observational studies. There are 1 or 2 proponents in the world publishing that testosterone should be used to prevent breast cancer. This is not data from placebo-controlled studies, and I would strongly recommend that this is not a course that one would take in clinical practice, because there is no evidence for this from placebo-controlled trials. We looked at adverse events, and that from you can see here the number of women in these different studies, testosterone versus comparator. Why is this number so much higher? Because a number of the studies, did a 2-to-1 randomization, and there was no evidence of a greater number of serious adverse events in women treated with testosterone during the course of these studies, the longest being 2 years in duration. So getting back to the patient's going to present to you because they're not happy with their low libido and they would like something done about it because it bothers them. So you need to formally evaluate your patients and make a clear diagnosis of HSDD. And this includes identifying other potential causes of low desire. So I refer you to this screening questionnaire, and this is freely available in the Clayton paper and also available through the International Menopause Society website, where you can find it included in the white paper in sexual function after menopause. And you basically go through and ask the first few questions, and then you go through the list of the questions in point 5. So basically, if a woman has another obvious cause like sexual pain or a partner's sexual problem as an underlying cause for their low interest in sex, and they do not have spontaneous or personal HSDD. HSDD is loss of sexual desire that causes distress that is not easily explained by another obvious cause like depression or antidepressants or dissatisfaction of the relationship. And I tell my patients that I might increase their libido, but I cannot make them like their partner. You need to explain to your patient that testosterone is a trial of therapy, because there really is no diagnosis. There's no test as to who is going to benefit. It's a trial. And a trial of therapy lasting 3 to 6 months after a cautious diagnosis of HSDD that involves a medical history, a psychosocial history, including asking about previous sexual, physical, and emotional abuse, and also asking about partner's health and so forth. You need to measure baseline total testosterone as a baseline, and also, as I said, to exclude women with an unexpectedly high testosterone. We also know women with an elevated sex hormone binding globulin above the upper limit of normal is unlikely to be responsive to testosterone therapy. You need to tell a patient they need to be a patient, because most studies have shown that if you give a physiological dose of testosterone, you do not see a benefit in total satisfying activity, improvement, sexual desire, and reduced distress for several weeks. So you see the desire starts to improve at about 4 to 8 weeks, and the peak is seen at week 12, and that's why we tend to review patients at 12 weeks, and then it's trial of therapy for up to 6 months. If there's no benefit by 6 months, stop therapy. We do not offer testosterone preparations result in supraphysiological concentrations, and usually we do not use pellets and injections. Because we have an approved testosterone therapy for women in Australia, there is no justification for using a male formulation or a compounded formulation now. Compounded bioidentical testosterone therapy cannot be recommended, and this is because there's lack of evidence for efficacy and safety, and the dose is a best guess. This is what is provided to other countries, but again is not relevant to Australia because we have an approved formulation for women in Australia. I know we have some internationals listening, and this is what may apply to you. The Global Position Statement members strongly recommended using an approved male formulation, graded dose, titrated dose, rather than a compounded therapy. In Australia, we have a recently approved product, and I'm again emphasize I'm not advertising this product other than the fact that it is TGA approved. The starting dose is 0.5 ml, and we ask women to put it on the lower torso and outer thigh. The reason being is that if you put it on the inner thigh overnight with the thighs together, you'll get an actual increase in blood levels and a different pharmacokinetics. If a woman puts it on her arms, there are 2 problems. There is possible transfer to a child or even a pet, and also it can mess up blood draws if she contaminates the blood draw site of the cubital fossa. I always check blood levels at about 3 weeks. I've told you women don't improve until several weeks later, but if they're applying too much and you draw their blood at 3 weeks, they'll have reached steady state. You can pick up the phone and say to them, please reduce your dose, you're using too much, rather than have them come back after 12 weeks and say, I've got this terrible acne. I tend to review patients at 12 weeks, and that's what's overall recommended. I've told you to stop therapy at 6 months. And if you continue your patient on treatment, you must review them 6 to 12 monthly, both with blood levels and also face-to-face. So both clinical and biochemical signs of overuse of the treatment. DHEA systemically does not result in a significant improvement in sexual function versus placebo and cannot be recommended as a treatment for HSDD. In some countries, vaginal DHEA has been approved for the treatment of dyspareunia. It is not approved for any other symptom. So in conclusion, low desire associated with personal distress is classified as having HSDD after other primary causes have been excluded. It is not diagnosed by a blood test. Testosterone therapy that results in a blood level that approximates premenopausal women total testosterone can be trialled to treat HSDD. Now, I just warn you, if you order a blood test of a total testosterone in a 55-year-old, you will get the reference range for a 55-year-old from your lab. So make sure when we're talking about approximating levels in premenopausal women, you're comparing your result for your 55-year-old or 60-year-old patient. You must compare that to a premenopausal woman's results, which you may not see in the printout that you received from your laboratory. And finally, presently, there are no other reasons to prescribe testosterone for women. So thank you for listening, and I will now hand back to our chair.
So we do have a few questions there. Thank you so much to Sue. You can, that's her name written all over everything. She has been there from the very start and she's still there. And I don't think it's the end for Sue yet. Touch wood, we all need her out there being the expert. So I'm just going to start with some of our questions here. And the first one is, in a perimenopausal women in their early 40s, who are considering testosterone use for low libido and they're already on hormone therapy, should the hormone therapy be stopped before starting topical testosterone? Is there a duration to wait for the effect of hormone therapy to wear off, or can the topical testosterone be commenced immediately after cessation of the hormone therapy?
So we've looked at testosterone in both women on concurrent estrogen or estrogen plus progestin, and women not on hormone therapy, estrogen or estrogen plus progestin. And testosterone can be used in either groups of women. So you can use it whether they're on menopausal hormone therapy or not. You don't need, I would hope you would not stop the hormone therapy. If you've got a patient who's perimenopausal and you've got on the pill, so I should add that the results of, we looked at peri and postmenopausal women together, so I'd include perimenopausal women with the postmenopausal group in terms of being able to treat them. The main problem is, in terms of stopping hormone therapies, if they're on the oral contraceptive pill and their sex hormone binding globulin is extremely high, you may want to get them onto non-oral estrogen before starting testosterone therapy, because we know that the testosterone will be unlikely to be effective if the SHBG is very high.
We have another question, and I think this is probably something to do with a piece of string, but how long can you use testosterone for?
So it's like the fisherman, you know, the one-armed fisherman. How big was the fish? The fish was this big. One arm. I don't know. How long's a piece of string? One arm. So as long as the patient feels they're benefiting. Quite often I've had patients say to me, I don't think this is doing anything. They've been on it for a year or two or 3 or 4. And I said, that's fine, stop. And they come back and said, I didn't realize it was doing something. So sometimes you have to stop, not just but encourage even the patient to stop the therapy in order for them to work out whether it's a benefit or not. And they have to revisit their time off it. And then other patients find it's not working for them, or things have improved in their relationships so much, or their sexual activity, quality of their sexual activity so much that they feel they no longer need it.
Another question, if we reduce the dose, do we reduce the daily amount or do we reduce the frequency of dosing?
So the available data indicates that the way in which we're prescribing it, it needs to be daily. So if a patient is found to be overusing the cream, then firstly, you do need to ask them where you're putting the cream. Because quite often I've found that they have decided to apply it to their arm because it's more convenient, and then you get a false result. So speak to the patient before titrating the dose, but if you titrate the dose down or even up, then you do need to have it as a daily dose. I find some patients don't absorb it so well. It's just like these patches and estrogen gel. We do all have different skin absorption. Some people absorb it very rapidly and get high levels. Some people absorb it poorly and will tell you it's not working. You look at their blood level, and if it in fact is very, very low, then you've got room to move to increase it. That's why blood levels are useful.
This one is, as there is significant variability of absorption of testosterone, is efficacy in women dose dependent? And there's another comment added to this, and I can read this again. The Intrinsa patch was not registered in part due to lack of efficacy and Libigel exclusively due to efficacy failure. How is the Lawley product different?
Okay. I'll correct whoever wrote the comment. I don't know who wrote the comment. I will just correct that misunderstanding. The Intrinsa patch was submitted to an expedited panel in the US, I think in, I can't remember now, 2002? No, later, 2003 or 4. 11 of the 14 panel members voted that the evidence clearly demonstrated the Intrinsa patch was effective for the treatment of HSDD. The reason it wasn't approved by the FDA panel was because the company provided insufficient evidence of cardiovascular safety, because they did not have the data at that point for the sufficient data at that point for effects on cardiometabolic profile, which was subsequently demonstrated. The European agency approved the Intrinsa patch as being effective for the treatment of HSDD, so it wasn't an efficacy issue. The Biosante gel was shown not, in fact, if you look at the study with Biosante, the efficacy was equivalent to the Intrinsa patch testosterone group for the testosterone arm. The efficacy for the placebo was as good as testosterone, and this is because the truth of the matter is the company was very inexperienced, and they started to find that women were dropping out of the study, and we see a 25% dropout in all of these studies. So they panicked, and they started sending women birthday cards and Christmas cards and gave them little gifts for coming to their appointments. So women who would normally have dropped out or said it didn't work continued in the study, and the placebo response was as good as the testosterone response because they actually broke every rule in the rule book. So it's a long answer, but it's an important answer because the misinformation is that testosterone does work and it's consistently shown to work, and that's not why it was not approved by the FDA. It is dose dependent, but as I said, there's a lot of imprecision in the testing, and you're testing for two reasons in terms of when on treatment. If a woman has very high levels, you want to pull her back. If a woman on review says, it's not working, doctor, and you realize that her blood levels are really no different to when she started, it gives you a safety margin with room to move to increase the dose. But you don't treat to target, you're not treating to a target dose, it just gives you room to move.
I'm going to go in a different direction with this question. This person has inherited a few people in women in their public clinic who are on oral DHEA, and they absolutely refuse to stop it, stating that stopping this will make them dysfunctional. And most of them in their 80s, so this doctor or health practitioner has complied, but they're looking for suggestions for help there.
So the global position statement's freely downloadable, and there is a statement about DHEA in it. And you can go to the International Menopause Society website and download the global position statement and show it to your patient. But there is not a single randomized placebo-controlled trial that has shown benefit of DHEA over placebo for anything, including sexual function, cognitive function, insulin resistance, prevention of cancer, diabetes, mood and wellbeing. It's been looked at across the board. The Dawn study was from Colorado Health Sciences, showed no value. The Mayo Clinic study was in older people, showed no value. That was published in the New England Journal. And so what they're talking about getting is a placebo effect. And I think that it will probably do no harm, but there is no evidence of benefit. And so I would do my best to get them off it.
How can premenopausal physiological replication be achieved if it's a non-cyclical application? In other words, is this not a pharmacological intervention not related to physiology, as there's not homeostatic feedback? The questions are tricky tonight, Sue.
Oh, that's a good question. So we never said it was physiological, it's a pharmacological therapy. So in the normal menstrual cycle, testosterone is at its lowest during the early follicular phase or menstrual phase, peaks at mid-cycle, and stays elevated during the luteal phase. But having said this, we're talking about going from 0.3 nanomoles per litre to 0.32 nanomoles per litre. So the change across the cycle in an individual in testosterone is really, really small. And so basically we never measure testosterone necessarily in a particular part of the cycle if you're looking for something like hirsutism, because you'll probably get the same level anyway. The change across the cycle is tiny. I would never say this is physiological because we're talking about treating postmenopausal women, replacing testosterone to a premenopausal level, or dare I say, an over 70-year-old level. But the reason we talk about approximating physiological levels in premenopausal women is because all the studies that have shown the outcomes of interest have been targeting those levels. So if you're trying to get higher levels, you are doing it beyond the level of any safety. So not physiological, I agree, it's pharmacotherapy. 2, we're not trying to do anything cyclical. In fact, we don't even know what the feedback is in young women in terms of the adrenal production. And 3, we're targeting physiological only because we know that's safe.
This is a nice question. It's got 4 words in it. What about with Livial?
The others were nice questions too. Livial. So Livial, as you all know, is a synthetic compound made from Mexican yam. It has a weak estradiol, testosterone, and progestin action, so you don't need to give a progestin with it. The testosterone action is weak, but it does result in a lowering of SHBG. And we have done a double-blind, double-dummy study comparing tibolone to a transdermal estradiol continuous patch where people got either a dummy patch or dummy tablet, and it was not more effective than the transdermal patch in terms of sexual desire and frequency of activity. The only difference was there was a slight advantage of tibolone on responsiveness to sexual overtures. So it's not nearly in the same ballpark as testosterone, but worth a try.
Another question, Sue. Do you need to wean off testosterone as we do with hormone therapy?
We just stop patients. Patients can just stop. It's not like they're going to get hot flushes and night sweats back.
Oh, that was a nice. And is there any circumstances you could use testosterone in a patient on aromatase inhibitors with hypoactive sexual desire disorder with distress?
So, as you know, aromatase inhibitors block conversion of androgens to estrogens, and therefore women on aromatase inhibitors, because of that, tend to have higher testosterone and androstenedione levels anyway, and DHEA levels anyway. We've shown that testosterone will improve sexual function even in healthy women on aromatase inhibitors. We did a study to look at that. Does it need to be aromatase to work? It doesn't. However, I personally would never treat a woman in that setting without consulting with her oncologist. And it is possibly worth a trial of therapy. In fact, we did a double-blind placebo-controlled study and have shown that intravaginal testosterone alleviates vaginal atrophy symptoms in women on aromatase inhibitors. So there is a possible role, but I think it has to be one of those things that's done in consultation with other treating specialists.
I love tonight's questions because this one's very interesting as well. Is there a minimum amount of time it needs to stay on the skin? This person is in the tropics and they sweat a lot and creams come off in the rain and with changes of clothes, etc.
So, bottoms in the rain. If the patients put it on their bottom, it's on their buttocks, they're probably less likely to get that wet, I hope. And really in that setting, patients can put on at bedtime, straight after a cooling shower, put it on immediately. If they're not putting it on their arms and they're, an exposed area of skin, it shouldn't be sort of rubbing off. And if, in terms of putting it on in the evening, if an individual has a male partner, there's absolutely no concern of transfer of testosterone to a male partner. A little bit more judicious in terms of possible transfer to a female partner.
This question is from a psychiatrist who intermittently comes across older women with chronic functional psychiatric illnesses who develop facial hair. They're asking for assistance. How can they help them apart from advising facial cosmetic treatments? So it's a little bit in a different direction, but I know you will be helpful.
Well, I guess the most commonly prescribed therapy in that setting would be spironolactone, but then one needs to look at other medications because we know spironolactone increases potassium, so it depends if they're on any ACE inhibitors, etc. The most long-term effective intervention for facial hair is going to be electrolysis or laser therapy. If they can't afford that and it is appropriate for them to take an anti-androgen, that can be considered. Cyprotot or anacetate is less popular now and not commonly used.
We are almost at the conclusion, but there are a couple that I think would be very worth talking about. Can testosterone be used in combination with Livial?
So because Livial reduces sex hormone binding globulin by about 45%, what happens is if you have a low SHBG, you'll get very rapid clearance of testosterone from the circulation. So in a study, this patient slipped into a study once. We were doing a pharmacokinetic study of testosterone, and they misunderstood and they thought Tibolone was HRT. So she got in the study, her SHBG was 7. She had the testosterone and we couldn't measure it in the blood because it was clearing so rapidly out of the circulation into her cells that you couldn't even tell she was getting it. And so very risky to combine it with Livial because you really can't monitor it, and the risk of getting androgenic side effects is quite substantial.
Also, what are your thoughts on salivary or urine hormone tests? And they have specifically asked about the Dutch test with thanks.
So salivary and urine tests have not been validated. It's very hard to measure testosterone in women. This is not being anti-salivary tests. Cortisol has been validated to be measured in saliva, but no labs in Australia have validation of measurement of testosterone in saliva. People have tried to do it. It'd be very nice and very clever and be very useful for men as well, but we don't do it because it's not validated, and therefore the correct test is serum.
I really want to thank Professor Davis for giving up her time and for all of you for being there and listening and for maybe listening to this later. I also would like you to consider, if you've enjoyed tonight, we usually have a very vigorous and very interesting congress, which is not just about menopause, it's about midlife, It's about women's health, and it's about good health in women from around midlife and beyond. And our Congress will be in Adelaide. We hope it will be an in-person Congress in late November. We hope everyone's vaccinated by then, and we'd love you to attend. We're really looking forward to a really great scientific program, and it will feel really amazing to be face-to-face again. Thank you so much, everyone, and thank you to the organisers and our sponsors. It's been really great to see you all, and take care. Bye.